All right, so hyperlordotic implants, there's been an explosion of them in recent years. I think anteriorly is where we really see the most common indication for them. Lateral, we've begun to have, I guess you could say hyperlordotic is the 20 and 30 degrees, but I think the 12, 15 degree lordotic implants I would consider more on the hyperlordotic side for lateral. With lateral, you really kind of have two different groups of these, with or without releasing the ALL. And then, posteriorly, there's been some more lordotic implants. Typically, what I've seen is more in the expandable realm, but I think that's certainly not as developed as the anterior or the lateral. In terms of the advantages, there's a potential to significantly improve lordosis at a couple of segments. The goal here is to avoid the morbidity of a big osteotomy. And then I think the other thing I've noticed is to better match native anatomy. So, sometimes you just have a very lordotic disc, and a 12-degree implant doesn't really match that, and you're going to lose some lordosis if you just put in the 8-degree or the 12-degree implant that we've classically had. I think the disadvantage of these is it's easy to get seduced by a 30-degree cage and think that the implant's going to do all the work for you. I think you can close down the foramen in the backside and cause some iatrogenic stenosis. And I also think that you can really edge load these things very easily, especially in the lateral space, and get subsidence or just drive the cage in, right in, like on rails on the anterior edge, right into the vertebral bodies on each side, and really not gain any of the lordosis you were looking for. And I think specifically in lateral, when you're getting in these more lordotic implants, whether that's really applicable if you're not releasing the ALL. I mean, in terms of the PSO, this is, in my opinion, these very lordotic implants in the deformity space, this is what you're really trying to avoid, particularly at L4 to S1. I mean, it's a good operation if you need it, but it's also a high complication rate. So, avoiding this really can be helpful for the patient if possible. In terms of Alif, certainly this is, in my hands, the most common indication for a hyperlordotic implant. Most of your lordosis, it's been well documented, originates from L4 to S1. Those are the easiest levels to reach anteriorly, and you're releasing the ALL, so you can really get much more of much more lordosis there. And there's been studies showing that you can get pretty good segmental lordosis that matches the cage lordosis at L4 to S1. The studies show that you get a little bit less lordosis when you're dealing with a slip, especially at 5-1, but you can still, with a 30-degree cage, get 17 to 19 degrees of segmental lordosis there. And you can do that even if you don't do a posterior osteotomy. I think certainly a posterior osteotomy is going to help you, but with the Alif, you can still get a good amount of lordosis. I think the technical note that I see is if you're going to do an osteotomy, I find that fixating to one vertebra is really key. You're not going to be able to hinge that open as much as you want. I think if you have 3 or 4 screws going into both vertebra, fixating it rigidly from the front if you're trying to get a big correction in the back. Lateral, I think that there's studies out there showing that you really don't change a lot of the lordosis with lateral. I think especially without an ALL release, the indication for a more lordotic than about 9 or 10 degree implant for me is really to match someone's native lordosis. I've seen several elderly patients where I'm doing a 4-5 lateral and they've got a very collapsed 5-1 disc and they're getting a lot of their lordosis through 4-5, and you look at that disc and go, like, that's a 12 or 15 degree disc. In those cases, I think a 12 to 15 degree implant is really appropriate just because you don't want to lose anything and you're really matching what they have, so you're not putting additional stress on them. But for me, I do a posterior osteotomy if I really want to make a big change in the lordosis if I'm using a lateral. I think with the ALL release, you can really get a lot of lordosis. Again, I think posterior-based osteotomies, combining it with that is probably important. And there's more risk. It's technically demanding in terms of the surgery. Do you get a lot more lordosis with lateral cages? There's multiple studies basically showing that for 10-degree cages, which aren't hyperlordotic, you get better lordosis of the segment, but not of the lumbar region. So it really doesn't change sagittal balance significantly. And I think that's the one limitation of laterals. I think it's very good for fixing coronal plane deformities, but I think if you're not releasing the ALL, it's not great at correcting sagittal plane deformities. If you do an ALL release and put a high degree cage in there in a cadaveric study, you can get more lordosis. But still, from what I've seen, I think you do better with an anterior-based approach, if possible, with the traditional Alif. My experience is, again, I think don't lose lordosis. If you need to put a more lordotic cage in at 4-5 to match the patient's lordosis, I think that's good. But I think that routinely putting in a 12 or 15 degree cage at L4-5 or 3-4 and not releasing the ALL, I don't think that's going to really improve your lordosis. I know I got kind of excited about 12 degree cages and 15 degrees when they came out initially, but unless a patient already was that lordotic at that level, I didn't really see that I was gaining a lot when I put those in. And so I've gone back much more to using the 10 and the 8 degree implants there. I think getting the implant more anterior will improve your lordosis. In terms of TLIF and PLIF, TLIFs can improve lordosis. I think the studies I've seen are that you can get about 10 degrees per level, especially if you combine it with an aggressive facet resection posteriorly. I haven't seen a lot about hyperlordotic TLIFs without doing a posterior osteotomy. Most of the studies I've seen don't impact lordosis a lot, more than a couple of degrees, unless you're doing a lot of posterior bony work. And then there was one study recently out that just said they didn't really see much difference in either the segmental lordosis or the overall lumbar lordosis between a static and an expandable cage. This is one case I did recently. This patient really didn't have real significant loss of lumbar lordosis, but he had a slip at 5-1 and then had a big coronal plane deformity, and it kind of auto-fused through that osteophyte at 4-5. So I wanted to get as much lordosis as I could and still correct his deformity. So I ended up going anteriorly at the bottom 3 levels, and I think put in a 20 degree cage at 5-1 and 14 degrees at 4-5, and I think an 8 degree cage just fit better at 3-4 as a first stage, and put the cage more toward the right at 4-5 to get that level flat, and then did a lateral at the top, and then just perk screws and got a pretty good correction. Then this was a case where I think a hyperlordotic implant did save this patient a lot of morbidity. She was an old Harrington rod. I looked at her and said, well, maybe we need to do a PSO. She's really in a flat back posture. This is her myelogram. She was stenotic at 4-5, mainly foraminal stenosis at 5-1. She's trying to get as much lordosis through those discs as she can. So I told her we might need to do a PSO. I did an anterior surgery from 4-1 initially and saw what her lordosis was, and then decided how much we needed to do on the back. In terms of what we did I put a 30 degree cage, I think it's a 30 degree cage in at 5-1, and then a 20 degree cage in at 4-5. And this was sort of my lesson. We got standing films on her, and she corrected reasonably well to where we didn't think we really needed a PSO in the back. So what I ended up doing was just doing a really aggressive facet resection osteotomy at 4-5, and you can see that even with a hyperlordotic cage, we were able to lever that even more and gain a lot of lordosis through there. And I thought 5-1, that's kind of my example of, we took off the facets, but once you've got 3 screws in there, you really can't move that segment much more to get much more lordosis. So, it's always a balance between, do you want more rigid fixation at that level to help it heal, or do you want to get more correction? I think in her, she was well corrected, but if I had to do it over again, I might just fixate the 5-1 cage to one of the vertebrae and get a little more correction through there. But we were able to just do a posterior, like a Pontiac type osteotomy, and avoid a PSO, and I think get a good result for her. So I think my final thoughts, I think for hyperlordotic implants, Alif works best. I think it's tempting in the lateral, but I think it's very easy to overdo it. And if you're really thinking you need to get a significant correction, really consider a posterior osteotomy, maybe an ALL release if you're comfortable with that technique. I think the more lordotic TLIF cages may better match the native lordosis, but again, probably need an osteotomy if you really want to make big changes. And edge loading can be an issue, especially in laterals and osteoporotics. Thank you. Yeah.